a new initiative for the BCI Thursday. So we used to be, as BCI Society, in particular the postdoc and students committee, is usually organizing this initiative of the BCI Thursday, and in which until now we always have one academic representative and one like from industry, or industry representative that can talk about more about the industrial part of the BCI. And now this is a new initiative that we just started. That is the one for the BCI user initiative, in which the idea is to have a research group presenting their research, and also their patient and their user, BCI user, that can also give their perspective on the use of the BCI, in particular the BCI for clinical usage. And I really push for this initiative because I think it's a really important also to have the feedback from the final user of this kind of initiative. So that's why I was like actually pushing for this initiative. I'm super glad that actually Lucas and Mathieu accepted to be part of that. So I think that I can basically start with a brief introduction of what we are going to talk today. And then I will leave the floor to Lucas and Mathieu. So Lucas is a research engineering specialized in ECoG based BCI for patients with motor disability in Clinatec in Grenoble in France. And he's responsible for the BCI training with patients, data processing and decoding, and as well both like actually the whole setting of the clinical trials. I have the pleasure to meet and collaborate with Lucas in the past months, and also with working with Mathieu De Graaf, that is actually, he's a hospital pharmacist, and he had an accident 15 years ago that caused a cervical spinal cord injury. And he joined in 2019 Clinatec for the BCI clinical trial. And today, so Lucas will present the research of his research group, and also we will have like the perspective of the final user of the BCI, so of Mathieu today. So I thanks a lot again, both Lucas and Mathieu, to join and agree in be speakers in today's event. As I said, this is the first time, the first meeting. BCI Thursday is focused on this new initiative on the BCI users. And so I think that I can give leave the floor to Lucas and to his presentation.
So thank you, Valeria, for the introduction. I will let me just share my screen. Okay, so can you see my screen? Is it loading?
Yeah, but not in the presentation. Okay, now in the presentation mode.
Yeah, okay. So thank you for the introduction. Hello, everybody, and thanks for having me for this inaugural BCI user episode. That's really nice, and we're really glad for that. And I will talk a bit. I will take basically an historical perspective of the BCI project we've done in Clinatec for 15 years now. And after, I will talk more about results we obtained with Mathieu in the past few years and current year. So just to start as an introduction, Clinatec is a research center in Grenoble that is a part of the CEA-LETI, which aims to develop and validate clinically innovative medical devices. So we work on two main topics, which are motor handicap and neurodegenerative diseases. We have actually a really transdisciplinary laboratory with a preclinical facility where we can validate early stage medical device, implanted medical device, and a biological platform associated with a biologist, and also all the technological stuff that aim to develop the implants. Actually, all the manufacturing of the implant is done in Clinatec. And at the first floor, we have a hospital unit where we can welcome our patient and perform the neurosurgeries. So it's a really nice transdisciplinary work environment, I would say. So one of the most known project of Clinatec is, of course, the BCI one. So I won't introduce here what is a BCI. I think everyone knows that. But yeah, about 15 years ago, Clinatec decided to develop a recording implant, ECoG recording implant, that would aim to control functional substitution devices for patients to improve mobility of patients with motor disabilities. So this implant you can see here is named WIMAGINE, and it has been designed in CEA. It's a chronic ECoG implant that records 64 channels and is wireless power supplied and possess wireless transmission. Actually, it's you can see on the head of Mathieu, it's invisible after implantation. It's generally implanted over the sensory motor cortex to do motor imagery BCI, and it's an ECoG, an epidural ECoG, which means that it's implanted over the dura mater, and it's making it well, let's say less invasive than microelectrode, for example. So in 2016, I think that was the beginning, the first clinical trial to evaluate the WIMAGINE BCI technology was launched. The idea was first to provide the proof of concept that it's possible for a tetraplegic patient to control a complex effector with ECoG. It was launched and supported by Professor Alim Louis Benabid and Professor Stéphane Chabardes, which is a neurosurgeon that performed the surgery on the patients. And yes, so the first idea was to control the exoskeleton. So we started with here is a video of our first patient that was implanted before Mathieu in 2017, and the idea was to show that he was able to control a very complex exoskeleton. Well, here is the working of the exoskeleton, so it's a simple model, 1D brain switch, but we did also experiments with much more complex models, such as 8D multi-limbs control, where he was able to reach different targets with control in 3D of the two hands and the pronosupination of both hands. So yes, that's it. That was we did with our first implanted patient. He was implanted 7 years ago, and that also gave us how to say a nice retrospective analysis of the data with a very nice stability of the ECoG signal over years. Actually, we have now 7 years of data within the different frequency bands, and we see that the data is very stable over years. We have the same curve with Mathieu's data now over 5 years. He was implanted in 2019, and it makes WIMAGINE a very nice for chronic recording and chronic use of the implant. We also showed after that the stability of performance of a model. Here we can see a model that is used in a virtual environment on the left, and we showed that this model could be stable for 6 months without any recalibration of the model. So again, this is a big step toward chronic use of a BCI implant on a BCI technology. So beyond the implant, this one made possible by our brain signal decoder that is based on neural features, time frequency neural features, so classical time frequency neural features, but it allows for real-time adaptive training of the model. So that's a main point. It means that the model are updated online with the patient during the experiment. I will talk a bit more about it later. And our model is based on a recursive exponential weighted Markov switching multilateral model. So in other terms, it's a supervised model. Okay, sorry. It's a supervised model that is based on experts, which are independent decoders that are dedicated to a group of degrees of freedom. And the gating function that allow to weight actually the expert and to determine which expert should be used to get the final prediction. So it allows to output a prediction and control the effector. I won't go into too much detail on the decoder, but yeah, basically that's a linear decoder with a classification part and a regression part on the experts. So how is the model updated during the BCI session? How it works in practice? For example, when we do a session with Mathieu, so the experimenter gives instruction to the patient via a visual interface on the screen that allow to cue the patient who can perform the associated motor imagery. Then neural features and instruction or labels for the decoder are fed to the model. Okay, sorry. Okay, are fed to the model that allow to update the model. The model is updated online. We can start a session with an empty model, and the model is updated online every 15 seconds. Every 15 seconds, a new model is set and is used to predict. In the same time, the model predicts emit a prediction to control an effector or a visual a virtual environment. When the patient and the experimenter are both satisfied with the model, the update is stopped and the model is fixed, and it can be used as a validation for evaluation without cues. It can be used without cues as a model. So this was a bit of historical introduction of Clinatec's BCI project. I hope it wasn't too much redundant of what you already know on BCI, but yeah, now I will talk about our current project, in particular what we've done with Mathieu this previous and current years. So first, there was a bit of change in the objective of the clinical trial after having shown the robustness of our implant and decoding environment. We've decided to focus more on functional tasks and functional effectors that could fit a home environment for the future BCI that could be used in home of the patients. Then we focused on two important tasks, namely mobility with a wheelchair and the reach and grasp task where we focused on two different effectors, a robotic effector and a functional electrical stimulation effector for reach and grasp also. So both effectors have their advantages and disadvantages. The robotic grasp, it has a very nice control of the hand, and it can be assisted with sensors, while FES can benefit from the use of the residual movement of the patient, and also some more and more studies show that it can promote rehabilitation. Both are transferable to home use, but yeah, time of installation and etc. have to be worked on, I would say. So we then performed different experiments with these effectors. The first one being evaluating a shared control BCI in a wheelchair driving task. The idea was to evaluate the assistance provided by a sensor-based chair control. So we sorry. We set up some different a model of decoding with 5 states that allow Mathieu to control a wheelchair up, not up, forward, backward, right, and left. And we did lots of training session where he has a circuit to repeat, and we did it with chair control and without chair control. The chair control device being lots of distance sensor placed all around the wheelchair, allowing to avoid obstacles and correct trajectories in case of facing a wall, for example. So you can see here the control of the wheelchair with chair control on the left and without chair control on the right, seeing that the trajectory is actually well corrected, and that Mathieu did not have to make like backward stuff and different maneuver to with the wheelchair with chair control, allowing him to perform way better in the circuit. So here are some of the results of this wheelchair driving. Yeah, just as you see on the previous slide, Mathieu was not in the driving in the wheelchair when he controlled it. He was just it was outside. He was actually in his wheelchair. This was of course because of security constraint, because we did some experiment without chair control, and yeah, we wanted to avoid collision, etc. So we evaluate first. Here you can see the evaluation of the BCI performance that were evaluated not with the wheelchair, just on a screen, with me providing him some cues of going backward, going upward, etc. And you can see the time it took to train the model. So the time is a time per cue, so per state. So you can see that at the first session, it was around 200 seconds, so 3 minutes per state to train the model. A bit more, maybe 4 minutes per state to train the model. And after that, the model was almost not re-updated between sessions. So sometimes to get better performance, we updated the model a bit, but mainly it was less than 50 seconds per cue to update the model. So it's really fast to get a good model back when we did a new session. Regarding the driving performances in the wheelchair and in the circuit, we observed that the chair control allowed to avoid all the collision and the loss of control. What we call loss of control is that sometimes we have to take back the control over the wheelchair because it's locked in a corner on Mathieu. The patient is not able to go back. So it was never the case in chair control, actually. The duration of the circuit was also reduced using chair control, and the number of mental tasks performed by Mathieu, we evaluated this by measuring the number of changes in mental task during the circuit, and it was reduced by 20%, and this is an important result that we could infer that it reduced the cognitive load of Mathieu during the circuit. So, and after this evaluation, we could nicely do some videos with Mathieu in the wheelchair, controlling the wheelchair in BCI. So you can see it here. Okay. we can see on the video the helmet that provided the power supply to the implants, and all the computing stuff is behind the wheelchair, and a sort of a backpack behind the wheelchair. So he was even able to go back. You will see at the end. It's a nice turn to go back in the right position. Okay. So the second experiment we did last year and also this year was a robotic arm experiment, and where once again, we wanted to evaluate a share control that was designed here in Clinatec, a share control framework that allow to grab the object. And contrary to most of share control frameworks that exist, it's not RGBD camera based, and that means that it allows, based on a distance sensor only, it allows to grab any object that exists in the environment. So we evaluated again this share control framework in the same kind of the same manner we did with wheelchair. So the idea was to evaluate the assistance, and you can see here again 2 videos with Mathieu controlling the robotic arm with chair control and without chair control. So we did again 5 training sessions and lots of repetition of not of the circuit, but yes, of the circuit, maybe of the task, which was task. It's going too fast. Again, we had very good BCI performances in decoding that again were tested only on screen. A very few misclassification between states. A bit of misclassification with idle, but never between states. That is, we think that is the more important, because when it's better not to perform an action than perform a wrong action, actually. And the model was trained again around 200 seconds per state on the first day, and after it was really low updating in a few duration, actually. Here again, we see a decrease in task duration, in path length that is performed on the circuit, and also in the number of mental tasks that is done to perform the tasks. So it's actually chair control allow easier tasks, faster, and with lower cognitive load. So these results were sent to Journal of Neural Engineering this year, and they are actually under review now. And the last effector we tested this year, this year with Mathieu, was functional electrical stimulation phasia, which is a sleeve stimulation that possesses 32 stimulation zones that we can install wrap over the arm of Mathieu, actually, and we can stimulate some pattern of open and closing hands. As you can see on the picture, due to a bit of spasticity in Mathieu's hand, the opening of the hand is a bit not very open, actually. So you have an application where you choose the electrodes you want to stimulate to close the fingers and to do the extension and flexion of the thumb, which take some time to configure, but it generally the parameters of the last session are are still good. So we evaluated first unimanual model of functional electrical stimulation for reach and grasp. Here you can see how the calibration of the model is going during the training. So at the beginning, we have a model that is not working at all. We start to train the open state of the hand. And during the time, the model is updating. So every 15 seconds, as I said, we have a new model. And you can see that at the end, the model is working much better than at the beginning, here in 300 or 400 seconds. Okay. Mathieu was able, sorry for the sound. Mathieu was able to perform, to use this model to perform some functional tasks with alloy tube. We choose to use alloy tube due to the opening on the hand, and yeah, we had a pretty nice control over the right arm. This is a 3-state decoding, actually. So yeah, you can see on the video, you can open and close the hand, and yeah, move the objects with stimulation. So that's that. These results are preliminary results that are in preparation for publication right now, actually. So yes, so I think here we are. Just to conclude, I will just present how other patients that are implanted, in particular in Switzerland. I talked a bit about the 2 patients that are implanted in France. So the first one that controlled the exoskeleton, and he was implanted in 2017. Mathieu was implanted in 2019, and we did more functional stuff. And in EPFL, there is now, in EPFL, in collaboration with the EPFL, we have now implanted 3 more patients in 2021, 2023, and 2024, where they are controlling an spinal cord stimulator to control to gain control over their walking or upper limb function. So, and as I already said a bit, our next steps and perspective are mainly to develop a fully embedded brain-machine interface. We have some projects that are financed for that, and the idea is to have a very usable BCI ECoG BCI at home. Here you can see on the video a patient in Switzerland that is actually already using the BCI in his home, but it's you can see he still has the computer on his walker, and he has to place everything and to make it work. But yeah, we're getting closer, actually. So yes, I think that's it. Thank you a lot for your attention. I hope I was clear, and yeah, maybe you can ask any question you want. Actually, I will come back on the presentation.
Yeah, so thanks a lot.
Thank you, everybody.
Wait, I think that, yeah. So thanks a lot, Lucas, for your presentation. I don't know if we want to do also the perspective of Mathieu right now and then all the question after, or maybe it's easier to do that and then.
Okay, perfect.
Yeah. We can do like that. So thanks a lot for the presentation. Super interesting work. I was already aware about that, but I'm happy that you shared about it, because I think it's super interesting, and I can't wait also for the final results of your work. We can actually, Mathieu, do you want to introduce yourself? You are confident with that? So, I mean, so that actually we can also see a bit of questions that can be interesting in for the BCI field from a patient's perspective.
Yes, Valeria, thank you. I can introduce myself. But at first, I am very happy to have seen the videos because I never saw them. So it was a good thing. I'm very happy. It was awesome to see that. My name is Mathieu. I'm 34. I had an accident when I was 19, so 15 years ago. I became quadriplegic because I had my neck broken. I stayed for about 2 years at a hospital and a re-education center. I started again my studies because before my accident, I was in the first year of medicine, and as I became quadriplegic, I chose to change, and I started pharmacy, and with success because I am hospital pharmacist now. In 2019, I decided to join the clinical trial in Grenoble in Clinatec. So it was 5 years ago, and I am happy to be part of this clinical trial. So I think it's a good start. So Valeria, I had some question I prepared. So how do you want I to do?
I don't know. There is so Lucas, do you have the slides of the answer, or is just like I?
No, I don't have any slides
Okay,
of
slides
my
on that.
writing
Okay.
answers. Yeah, so I was thinking more about yeah,
Yeah, just asking. Yeah, so
just
I
asking
mean,
and discuss.
okay, perfect. So, perfect. So, I mean, like I prepare like some questions that could be of general interesting for the BCI field and researcher also that are approaching or that are already experts in the field that I see also in the participants of this talk today. So the first question was actually, why did you decide to participate in the BCI experimental protocol?
I decided to participate in the BCI protocol because I found the concept was extremely innovative and full of promise in the long term. So I had several discussions with scientists for 3, 4, 5 months. And after that, I decided to participate in this protocol, in this adventure.
Okay, no, so it's perfect actually because we know like also this is an invasive BCI, so actually there is a surgery and an implant for going through, so that's why actually it could be also an interesting question. Why I mean like it could be one BCI user can actually decide to participate. So actually my next question would be about what you benefit most from participating in the experimental protocol. So what do you think was the most, more beneficial part of being part of this BCI clinical protocol?
So in fact, this protocol, this BCI protocol, itself doesn't bring me any benefit. So it was clearly explained to me when when I started, when I talked with the scientist, that the interest was truly scientific. So I think they are still only the beginnings of this technology. So it needs to make sure so that it can one day be used routinely in patients. And I am very happy to be able to contribute to this development of this technology. And also, I think that since I started at the end of 2019, the technology has improved, as Lucas show with the other patients who can walk for the paraplegics. And so during these periods, when I am at the research center, I am so as I have already said, I am very happy to work with the scientists and to be more precise. In fact, I come to Grenoble to the research center about 2 weeks, all with 2 months of break. So I live in Lille, in the north of France. I work 2 months, and I go to a center 2 weeks. So it's how it's organized.
No, so that's actually super nice because actually, as you mentioned, there is also like you are not living in Grenoble where the actually the experiments, the clinical trial is going on. So I think that actually, yes, no, you are contributing to this scientific evolution that can bring some benefits also to a lot of people in the future. And I see a trend on that. So I think that's super exciting. And so my third question would be actually, what does it feel to have a BCI? So when you use it, it's like, I mean, what do you feel when you use the BCI itself? Because of course, with like, I'm always worked with actually non-invasive BCI. There's a little bit difference because it was more for rehabilitation. Instead, like with invasive BCI is more for control. So I would like to also to have your opinion on how it is to really use a BCI.
So as I said, in my opinion, there's still a long way to go because it's just the beginning. And in fact, some days the exercise are really frustrating because nothing will work. So well, it's not, of course, not every day. It's not often, but sometimes it doesn't work because of me, because I am tired, because of the algorithms, because of bugs. But on the contrary, when it works, it's really a pleasure. As you could see, the videos when I controlled the wheelchair of or le bras robotisé, Lucas, je sais pas si
The robotic arm.
robotic arm. Sometimes it works very well, and it's really easy, and as I said, it's a pleasure to use because all I want to do, it works. And so now what I can return, it's when it works like that, it's really a feeling of satisfaction. Even it's really complex, and we can see it works. I think it's awesome. Really, it's finally, I think it's the most important feeling I can I can say. Voilà.
Actually, you explain it really well. You explain extremely well how you feel, and I think that you also mentioned something super important: the fact that not always things works. This is research, and this is actually when students come and things that like, okay, working in BCI is amazing, so let's do it, and then they feel, oh my God, like what there is these bugs and so on. They actually, this is like a lot of work behind to make the BCI work. So in research, this is actually what happened, and then actually it happens to make these kind of feelings, no? So to make someone feel super satisfying in using then it. So it's completely worthy. So that's actually useful for students to know that.
Yes, and but maybe in some years it will work for several patients. So it's a feeling of useness. No, I don't know if it's the good word, but I feel my usefulness.
Yeah,
So
it will
they
be
have
useful for next patients. That's
yes.
Yeah, no,
So,
yes, that's completely true. So
sorry,
actually,
French people don't speak very well English.
oh, you speak super well, actually. No, don't worry. Actually, thanks a lot. And so my next question is more a technical question that lots of researchers actually are trying to figure out because there is always a trade-off between like having a BCI with a high accuracy and like having a BCI that is actually fast. And so also that doesn't need a lot of calibration. So from your perspective, do you think that like you can be more likely, like, do you prefer to maybe have something that is fast to wear and use, or something that actually is super accurate but needs a lot of calibration? I know that is a technical question, but it's more actually how you perceive it.
I think it's important to have a good model calibrated from the beginning, even if it can take a lot of time. Because if the model is not good, I don't think it it's interesting. I think you must take a lot of time at the beginning, and as we could see on what Luca shows, the model which lasts 6 months without recalibrating. It was not with me as the patient, but I think there was a need of a lot of time to calibrate, and we can see it was very good. So I think it's necessary to take time to calibrate.
That's actually super useful because, of course, like the accuracy has to be high, and so even if it takes long, it's like worth it to, in any case, have something super accurate in that case. And so, that's actually like more like, which is also the biggest barrier that you face when you, which is the most difficult part in using the BCI. So, for example, the fact that you have to travel to Grenoble from Lille to have it because there is no places, for example, close to you to have it, or so what is the actually, like in general, like in daily living, have like the biggest barrier you face when using or adopting the BCI?
For me, in my opinion, to travel, it's not a problem. Everything is really well organized with the center to me, the patient. Everything is done I am in good conditions. I have a flat with people to help me, and I am happy when I go to the center every day with days off. So if all the centers are organized in the same way with the patient, I think it's a good point. No, the things which are which may be which must be improved. It's to be sure that when a model works, it must be stable for a long period. It's what we said before. So it's not finally it's not organization. It's really we leave the model, the protocol. I think it's really the thing which must be which can be difficult when the model is not stable. And I think it's essential to consider having a use in real life.
Okay, so actually, this is actually come to my next question that you are actually partially already answered to. That is, what do you think actually like researchers should focus most to improve the functionality of the BCI? So you say the stability across time, a long time, right? So you think
Yes,
that like the stability of the model a long time.
And also the algorithms, which are not yet perfect, with as we could see on the what Lucas has shown, they are still bad. There are still errors in decoding mental tasks, as we could see when I fought to go to the right with the wheelchair. There is sometimes it understands to go to the left, or so I think there is still a need to improve the models to not have decoding errors.
I think that actually is something that everyone in the BCI field is working on, like hardly. But yeah, it's true. Like to have like a model that is actually accurate and that is stable across time. I think because now we know that it can work, but the most important time that now I think that like the researcher in this field should focus on is the stability across time and having something that is as less error as possible. So to really use in the daily life in this sense. And so my last question, and then I will leave also the floor to the other to the audience that can ask some question in the Q&A. Do you actively actually check the news about, because now there is a lot of we see a lot of in the news about the BCI and so on. So there is a new trend actually also for the public audience about the BCI. So do you usually check this kind of news, or do you check also scientific paper on the BCI, or you just know and like just with your project and that's it? Like I'm curious to see if like you are actually up to date, let's say, on the BCI technology itself.
No. Me, I don't actively search information. Scientists in Clinatec give me a piece of information about what it happens, especially about the patients in Switzerland. But me, no, I'm not used to search information about other projects. But now maybe the other first day I will connect with pleasure to to see what it can be said about the other projects.
That's actually super interesting. I'm actually glad that you like this kind of conversation and talks, and because I know also that there are some BCI user society that only for user and patients that are using that they can share their opinion on that and so on. So I'm glad that this can be a tool for also the BCI user to check and be up to date about the new in the new development and the new achievements in the BCI world, actually. So okay, so that's amazing. I'm really glad of it because I really like. I think that this initiative is super useful for both the researcher and the BCI user. So I'm happy that actually the BCI Society decided to organize it. So basically we can start with the Q&A. If like from the audience, everyone has some questions, can raise their hand or can type the question in the chat. So someone has some question, I don't know. Brendan, he's like streaming our event in a class. So I don't know if someone in the class also have some question on it, feel free. And okay, I will give the floor, the word to you.
Yeah, certainly. If anyone in the class has questions, great. I have a question, but I just first wanted to thank you for doing this. There has been a lot of effort to engage patients in different ways, and this is wonderful. I noticed that Jen Collinger is online, who was our last president, and so I'm happy about that. My question is similar to the questions that others have asked about independence, about the need to travel between Lille and Grenoble to interact. What would be necessary to make this BCI system fully usable at home so that there is no need for ongoing maintenance? I know that's very difficult. I was just lecturing about it today. What would it take with your group?
Okay, so actually we're working on it. Mathieu is equipped, I would say, with an old device that was now 5 years ago, and now we have very tinier things and decoders and stuff. So we're getting much closer from home use. And after it depends on the autonomy of the patient to make updates of the models, for example, or to wake up the BCI. We also are working on the usability, the ease of use. Actually, now we have some of AV programs that make the decoding, and we have to reduce it and to make it portable and usable at home. But we are not so far from it, actually, and there is really I'm practically useless when we are doing okay. If the patient is autonomous in updating the model, knowing which state is not working, which state is working, and what to update, how to update it with maybe clicking on stuff like that. We could go at home, actually, without any problem. Now the updating part is doing with an experimenter, but that's the main part. Okay, so
thank you.
And maybe Mathieu has some. Valeria, your mic is off. Maybe Mathieu has some insight also on what it would need to be used at home. I don't know.
To improve the models, I think it's possible to do it at home, now, for example, when it was the COVID, the scientist was in Grenoble, and me, I was at home, and we worked like this for some weeks. It was okay to improve the models, but after to use effectors, I think maybe it's more difficult. I don't know. I don't know what to say. It. I think it may depend on the effectors.
Yeah, but Mathieu raises also a good point that the need of building effectors that can be used at home. Actually, currently, for example, the functional electrical system, functional electrical device is hard to put without an experimenter. That's the effector part is important too. To control a cursor on a screen is easier than to control a robotic arm at home. Or there is also a lot of security check to have before installing a BCI robotic arm in the patient home.
Also, I think it's important to find the effectors which will be useful for the patient. For example, me, I am incomplete quadriplegic, so I can move my arms. I can eat with a spoon, with a big spoon. I am able to control my wheelchair, my electric wheelchair by myself. So far, the effectors we used in the clinical trial are not useful for me, but I think they will be very useful for people who are, for example, complete quadriplegic or other diseases. So me, I will have no interest by myself to use the robotic arm to control the wheelchair with BCI, while I'm able to do that. So I think it's also a thing to discuss.
Okay, thank you.
Yeah, thanks a lot. There are other questions from the audience? No? No, I don't think, even in this chat, I don't think that there are other questions. Okay, perfect. So thanks a lot again for both Mathieu and Lucas to be here today and for everyone to attend it. I think it was like really inspiring and really like super useful for everyone in the BCI field. So I'm really glad that you join us and you accepted to be speaker today. And then, I mean, also that this kind of event can be useful for both the users and the researchers, as I said. So, I mean, yes. Thanks, Franklin, because thanks so much for sharing this talk. And then, before closing, actually, I would like also to remind that there is another BCI Thursday event on November 7. So I will share actually in the group the like the link so that everyone that is interested can go and like register. It will be more about the ethical part of BCI, since now there is more and more the growing of the BCI, of the invasive BCI, and how actually, so this could be ethically managed, let's say. So we will have two experts oh wait, there is a question, so because I'm actually checking also the chat, so I got distracted, but yeah, so there will be two experts in BCI for ethics, and they will present on November 7, and in the link you will find all the details. So there is actually a question from Zach that say, I would love to hear more about your experience with the shared control. For example, how is the interplay between the intention detection aspect of the BCI system compared to the wheelchair smart control system? Lucas, I think that the question is for you.
Yes.
I mean, I don't know.
I don't know.
Yeah, it's more maybe from Mathieu, but maybe yes.
The experience is more from Mathieu's side, I think.
Yeah, that's true. Sorry.
Yeah. How?
Alors, before I answer, I want just to be sure to understand how is the interplay.
C'est comment ça se passe, le passage? Est-ce que tu sens le passage entre le BCI et le share control, et comment les deux se rejoignent? Comment tu la ressens?
When I used for the example of the wheelchair, Lucas' shoe, it was le parcours, c'était the trip,
circuit.
The circuit with the wheelchair. Sometimes it was difficult to turn because it was really
narrowed.
So the risk was to hurt the wall, and when there was the chair control, the wheelchair moved to not hurt the wall. It was really helpful for me because I didn't have to think, oh, I must be really be careful because I risk to hurt the wall. It was easier for me because I knew I will have no problem, and it was really helpful. I think it's what I can answer.
And just to add, in the algorithm, we try to make the transition between user intention control on the on the sensor control the smoother possible. So at the beginning, it's completely BCI control, and the closer the wheelchair or the robotic arm is to the object, the more the sensors take the control. It's not an on-off device, actually. And between this part, the control is shared between the user, half, for example, it's between the user control and the sensor. So it should be smooth. It's designed to be smooth, actually.
Okay, so basically it increased the safety and also the smoothness in the movement, and also so you are more confident when you are controlling the wheelchair with the share control. That's actually super interesting, though. Okay, thanks a lot. So, I mean, I think that we are running out of time, basically. I don't want actually to stall more time of you. And so thanks a lot, both Luc and Mathieu, to be here today and everyone to participate in the talk. And like, I hope to see you soon, actually. So,
Thanks for having us. That was really nice event. Thank you, Valeria.
yeah, thank you. Thank you to all. Bye.